Lower is not always better. For older adults, pushing blood pressure down to 120/80 can cause dizziness, dangerous falls, even hospitalization. Today, I'm going to show you the safer truth. What best blood pressure really means for seniors, and how to find your personal target without sacrificing your balance, your brain perfusion, or your quality of life. I won't give you the exact number yet, because if you leave with a number, but not the why, you'll miss what protects you most. Stay with me, and by the end, you'll know your safest range, how to test yourself at home, and how to talk to your doctor about it, step by step. I'm Dr. David Chen. For 2 decades in cardiac care, I've watched a single myth harm older adults, that 120/80 is ideal for everyone. That guideline came from studies in younger, healthier people. When we apply it to seniors, we often see orthostatic hypotension, blood pressure dropping when you stand, leading to falls, fractures, cognitive fog, and kidney stress. Newer research in real-world older adults shows a different sweet spot. In the next 25 minutes, you'll learn why seniors need different targets, the ranges that tend to be safest by age and health status, exactly how to check for standing drops at home, how to tailor meds with your doctor, and a simple breathing plan you can use to lower pressure without overmedicating. Before we begin, comment your age and a recent home reading, just the numbers, and whether you feel dizzy when you stand. That pattern matters more than any one measurement. Let's start with the why, because understanding your physiology is the key to choosing a safe target. As we age, arteries stiffen. Young, elastic vessels absorb each heartbeat's pressure wave and help maintain steady flow to the brain. Stiffer arteries don't. That means older adults often need a little higher systolic pressure to push blood upward against gravity, especially when standing. Pair that with baroreceptors, your pressure sensors, that become less responsive with age. In your 40s, when you stand, those sensors rapidly tighten vessels and quicken heart rate to hold pressure steady. In your 70s and 80s, that adjustment can lag. If your baseline is already set very low, the drop on standing can be severe. Then there's medication sensitivity. Kidneys and liver clear drugs more slowly in later decades. The same dose that's fine at 55 can overshoot at 78, pushing you into the too low zone, and the risk calculation changes. For a 50-year-old, the main threat is decades of vessel wear from high pressure. For an 80-year-old, the immediate threat can be a sudden fall from pressure that dips too low. A hip fracture can steal independence in one morning. I'll give you one composite story drawn from many patients. A 78-year-old got to 122/78 on 2 medications. Lying down, fine. Standing, her pressure crashed to the 80s/50s. She felt a violent head rush, fell, fractured her hip, needed surgery, and spent weeks in rehab. The number looked perfect on paper. In her body, it was unsafe. The issue wasn't the couch reading, it was the standing drop. Keep that in mind. Supine perfection can hide standing danger. For years, the medical world celebrated lower and lower targets, largely based on trials of middle-aged patients. One famous trial that pushed for intensive lowering excluded many seniors with common conditions like diabetes, prior stroke, or frailty. When we look at older adults who actually reflect real life, people over 75, including those with multiple conditions, patterns shift. In large cohorts of adults over 75, the lowest risk for falls, fainting, kidney injury, and death tends to sit around a moderate systolic range, not below 120. Seniors whose average systolic stayed roughly in the 100s and 30s generally fared best, while risk rose when the systolic was pushed under 120 or allowed above 150 for long stretches. Why? Moderate pressure maintains perfusion to the brain and kidneys, while still avoiding the vascular stress of sustained high pressure. It's that middle ground that best balances safety and protection for most older adults. Now, I'm still not giving you a single number, because it's not one size fits all. Instead, I'll give you practical bands that you and your doctor can tailor. If you're 65 to 75 and generally healthy, many do well with systolic in the 130 to 140 range, with diastolic often between 70 to 85. If you're 75 to 85 and relatively healthy, 135 to 145 systolic is often reasonable. If you're over 85 or frail at any age, 140 to 150 systolic commonly prioritizes fall prevention and brain perfusion. Important nuance: diastolic matters too. Keep it generally above the mid-60s, ideally 70 to 85. Very low diastolic, below approximately 60, can starve the heart and brain during the relaxation phase between beats. Let's make that concrete with two contrasting examples, simplified from real cases. A healthy 72-year-old at 146/88 felt awful when pushed medically down to the 120s, fatigued, dizzy, foggy. Loosening to the mid-130s restored clarity and energy. Same age, different context. A 72-year-old with diabetes and prior heart attack did better closer to 130/80, lower, but not the 120/80 of a much younger elastic artery physiology. The principle is simple. Healthy, active seniors often thrive in the 100s and 30s systolic. Seniors with high vascular risk may benefit from the low 100s and 30s if it's well tolerated. Frail older adults are often safest a bit higher. In every case, the standing test is the tiebreaker. Pulse pressure, the gap between systolic and diastolic, naturally widens with age due to stiffening. That's why you might see numbers like 150/75. The key isn't forcing that top number down to textbook ideals. It's protecting you from standing drops and dangerous lows, and from sustained very high elevations. So how do you determine your personal sweet spot at home, then confirm it with your doctor? Step 1. Measure where you live, not just in the office. Take your blood pressure at home, morning and evening, for 2 weeks. Sit quietly for 5 minutes beforehand, feet flat on the floor, back supported, arm at heart level. Use a cuff that fits your arm properly. Log every reading. Single spikes or dips are normal. What matters is the pattern. Step 2. Check for orthostatic hypotension, the standing drop. Lie down and rest 5 minutes, then measure. Stand up and measure immediately while standing, then again at about 3 minutes. If your systolic falls by 20 points or more, or diastolic by 10 or more, that's orthostatic hypotension. Example: 130/80 lying, 105/68 standing is a 25-point systolic drop, meaning you need a higher safe baseline or fewer meds to prevent the fall risk. This one test has prevented more injuries in my older patients than almost anything else. Step 3. Listen to your body. Dizziness on rising, gray-out vision, brain fog, fatigue, or difficulty concentrating can all be signs of pressure that's too low for your physiology, especially if they improve when your reading is a bit higher. On the flip side, persistent headaches, shortness of breath with exertion, or swelling that tracks with elevated pressures may signal you're running too high. Symptoms plus standing test plus 2-week log tell the story. Step 4. Bring your log to your doctor. This isn't a prove-it battle. It's a partnership. Share your home averages, your standing drop results, and your symptoms. If you're in your 70s or 80s, feeling unsteady, and your standing numbers crash, that's powerful data to adjust your target upward, safely. If you're in a higher risk group, like diabetes or prior stroke, and tolerate lower readings without dizziness or drops, aiming for the low 100s and 30s might make sense. Your whole health picture sets the target. Step 5. Adjust gradually. One change at a time, then recheck your standing test and 2-week log. The goal is a range you tolerate, morning and evening, with no dangerous dips when you stand. If diastolic slides below about 65, that's another signal to slow down or revisit the plan. Step 6. Reassess regularly. Bodies change with age. The target that worked at 70 might be different at 78. Repeating the lying to standing test every 6 to 12 months helps you stay in your safe zone. I want you to hear how this looks in daily life, because numbers only matter in context. A 74-year-old had perfect office readings around 128/76 but felt woozy when he stood. At home, lying pressures were near 128/76, but standing fell to 98/58, a 30-point systolic drop. We eased one medication, and his couch readings rose to the mid-100s and 30s. Standing, he stabilized around 118/72. His dizziness disappeared, and he stopped living in fear of getting out of bed. Was 136/80 too high? Not for him. He regained function and safety. An 83-year-old who was frail ran 160 seconds over 90 seconds at home. Instead of forcing her down to 120/80, we weighed risks. A hard push might have triggered standing drops and a hip fracture. We accepted the 100s and 50s to 100s and 60s with close monitoring and a strong fall prevention plan. She remained steady, independent, and out of the hospital. For her, avoiding a catastrophic fall mattered more than a textbook number. A healthy 70-year-old golfer sat around 140 to 144/84, felt great, and had no standing drop. We left him alone. The marginal benefit of pushing him to 120/80 wasn't worth the risk of side effects and dizziness. He kept playing, traveling, enjoying life. Proof that treat the person, not the number, is more than a slogan. And a 76-year-old at 118/72 felt weak and confused. Standing, she fell into the 80s/50s. We revised meds, landed near 138/78 with stable standing numbers. Her energy returned, her mind cleared, and she got her independence back. Same person, better life, because the target fit her physiology. If you discover your average is higher than you and your doctor want, you have powerful tools that don't compromise your standing safety. There's a safe way to bring pressure down without piling on medications or triggering standing crashes. Slow, paced breathing. Your breath controls your nervous system. Fast, shallow breathing amps stress hormones and constricts vessels. Slow, steady breathing activates the parasympathetic rest and digest pathway, dilates vessels, and lowers pressure, often within minutes. 2 techniques you can start today. Resonant breathing, inhale for 5 seconds, exhale for 5 seconds, smoothly through the nose if comfortable. That's 6 breaths per minute, the rate that balances the cardiovascular system and improves heart rate variability. Practicing 5 to 10 minutes once or twice daily nudges your baseline lower over time without forcing unsafe dips. 4 to 7 to 8 breathing. Inhale through the nose for 4 counts, hold for 7, exhale through the mouth for 8. That extended exhale turns up the relaxation response. 4 cycles can ease pressure within a couple of minutes. If you feel lightheaded early on, just shorten the hold slightly and keep the exhale longer than the inhale. For emergency spikes, like white coat anxiety, alternate nostril breathing can calm the surge quickly. Right thumb closes right nostril. Inhale left for 4. Close left with ring finger, open right, exhale right for 4. Inhale right for 4. Close right, open left, exhale left for 4. Repeat. 3 to 5 minutes often brings a noticeable drop and steadier heart rate. Let's do 1 minute together, gentle and safe. Sit tall, relax your shoulders, one hand on your belly. Inhale for 5. 1, 2, 3, 4, 5. Exhale for 5. 1, 2, 3, 4, 5. Again, in. 1, 2, 3, 4, 5. Out. 1, 2, 3, 4, 5. Keep going at your own pace while I talk. You can use this in the waiting room, before difficult conversations, or anytime you see a higher reading and feel stress rising. It's discreet, free, and under your control. If you have severe lung disease like advanced COPD, check with your clinician before starting, and never replace prescribed treatment. Use this alongside your plan. I've created a companion video that guides you through each technique with timing counts you can follow in real time. Watch that next to practice and lock in the habit. Here's how to turn this into action today. First, establish your baseline. Over the next 2 weeks, take morning and evening readings at home and write them down. On 2 different days, do the lying to standing test. Measure after 5 minutes lying down, then immediately upon standing, and again at 3 minutes. If your systolic drop is 20 or more, or your diastolic drop is 10 or more, that's orthostatic hypotension. If you feel dizzy when you stand, that's a clinical red flag, even if the numbers are borderline. Second, reflect on symptoms. Are you steady or unsteady, clear or foggy, energized or drained? Bring your log, your standing test results, and your symptom notes to your doctor. If you're 65 to 75 and healthy, discuss a systolic in the 130 to 140 range. If you're 75 to 85 and relatively healthy, 135 to 145. If you're over 85 or frail, 140 to 150. If you have diabetes, prior stroke, or heart disease, you may consider the low 100s and 30s, if and only if you tolerate it without standing drops or dizziness. Keep diastolic generally above the mid-60s, ideally 70 to 85. Third, if you and your doctor adjust medications, change one thing at a time. Recheck your standing test after every adjustment. Your goal is not a trophy number, it's a stable, safe range you feel good living in. Fourth, layer breathing practice into your day. 5 to 10 minutes of resonant breathing in the morning and evening, plus 4 cycles of 4 to 7 to 8 when stress spikes, can lower your average a meaningful amount without risking a standing crash. That's the art and science working together. You now know the truth. For older adults, the best blood pressure isn't the lowest possible. It's the safest sustainable range for your physiology. Arterial stiffness and slower baroreceptors mean you often need a little more pressure to perfuse the brain and prevent falls. Large, real-world cohorts of seniors show that systolic in the 100s and 30s, with diastolic around 70 to 85, is often the sweet spot, lower risk than the 100s and 20s for many older adults, and far safer than letting pressures drift into the 100s and 50s and beyond long-term. Orthostatic hypotension, your pressure crashing when you stand, is more dangerous than a mildly elevated couch reading. The standing test, plus your symptoms, should guide your target with your doctor. And when you want to reduce your average safely, breathing practices give you a powerful, side effect-free lever. If this helped you, share it with someone over 65 who's dizzy when standing or struggling to hit 120 over 80. Comment, "I understand," if the safe ranges make sense, and tell me your age and whether you've measured a standing drop at home. I read the comments and bring common questions into future videos. Now use the relink I promised. Everything we covered today works even better when you know how to lower pressure in minutes without overshooting. Watch my guided breathing session next. Seniors. 3 breathing tricks to instantly lower blood pressure, so you can practice resonant breathing, 4 to 7 to 8, and alternate nostril breathing with me and feel the effect in real time. Then, bring your 2-week log, your standing test, and your experience with these techniques to your next doctor visit and set a safer, smarter target together. Thank you for watching, for advocating for yourself, and for choosing function and quality of life over a one-size-fits-all number. Subscribe for evidence-based heart health tailored to the realities of aging. I'll see you in the next video to practice those breathing techniques step by step.